Thanks everyone for being here, those of you in the room with us and all of you on WebEx. We really appreciate you. As usual, if you have questions or comments for our speakers, you can type them into the chat and I will read them out at the end of the presentation. Today I have three wonderful people to introduce, and we are thrilled to welcome our visiting professor, Dr. Kenya Kailemia. She is one of the first graduates of the Combined Fellowship Program in Pediatric and Critical Care at the University of Nairobi, where she also did her pediatric residency training in pediatrics. She now leads the pediatric ICU at Kenyatta National Hospital, or KNH. She trains nurses, medical officers, residents, clinical officers, and pediatric emergency critical care fellows. She also chairs the Pediatric Risk Management Committee and the CME Committee at KNH. She is passionate about research, training, QI of pediatric critical care in Kenya. We also have Dr. Emily Hartford, who is an associate professor in pediatric emergency medicine here at UW and Seattle Children's, where she focuses on equity research, global health, and collaborative educational projects with the REACH pathway and the pediatric emergency medicine curriculum development and implementation with PECC Kenya. And then we also have Dr. Amelie von St. Andre von Arnim. She's an associate professor in pediatric critical care. She helped co-found the PEC Kenya Fellowship with collaborators at the University of Nairobi and Kijabe Hospital in Kenya. She continues to oversee the virtual curriculum for fellows, as well as participates in on-site education in Kenya. She's involved in various research projects focused on improving outcomes of critically ill children in resource-constrained settings. So excited to have all three of you superstars here today. Welcome to all three of you, and you guys all have to clap loudly.
Thank you, Dr. Mazer, for that lovely introduction. Hello, everyone. It's such a privilege and honor to be here with my amazing colleagues, especially Dr. Kailemia, all the way from Kenya. She was supposed to be here in July 2020, so we have finally managed to reschedule that ill-timed visit, and we're thrilled and having a good time. So I'm going to start us off today. We're doing a joint presentation on narrowing the child mortality gap, investing in leaders to strengthen emergency and critical care across Africa. There we go. So this is what we'll talk about today: the status of global child mortality. I'll cover also access to pediatric and critical care across Sub-Saharan Africa, and then we'll go on to the development of PEC Kenya, and then finally the current status of critical care at Kenyatta National Hospital and opportunities for the future. So the overall story about global child mortality, and especially under 5 mortality, is positive. Over the past 30 years, there's been a reduction almost half in global child mortality. This is showing the most recent IGME report from 2023. It shows from 1990, where the mortality has been cut almost in half to 2022. But still, that means 4.9 million children died under 5 in 2022. That's 13,400 deaths a day. That's 9 deaths a minute. And that means around the world, 1 in 27 children, if you could just imagine 27 children, 1 in every 27 will die before their 5th birthday. And there are huge disparities by country and by region in your risk of mortality and your likelihood of survival. This is showing the under 5 mortality rates around the world. The lighter colors are lower mortality rates, the darker colors are higher mortality rates. And this is under 5 mortality. And there's a huge difference. You see right away that Sub-Saharan Africa has some of the highest under 5 mortality in the world. And the difference when you compare regions like Sub-Saharan Africa to the lowest mortality regions like Australia and New Zealand is 18-fold. And when you start looking at individual countries, the difference between the highest mortality countries, the lowest mortality countries is 80-fold. So just this massive difference depending on where you're born in the world and the likelihood that you'll make it to your 5th birthday. And this is also some other types of inequality, so no longer by geographic distribution, but now we have inequality by income, by maternal education, and by urban versus rural place of living. So on the left there, you see wealth quintiles, and the highest under 5 mortality is the lowest wealth quintile, and it goes down with almost a linear relationship. As you gain wealth, you have lower under 5 mortality. And same with maternal education there in the middle. So with no or lower maternal education, you have higher under 5 mortality rates, and then it drops quite dramatically as you get through primary, secondary, and higher amounts of education for mom. And then there in green, you have urban versus rural. So the lighter green being rural location and the darker green being urban. So all of that was under 5 mortality. Now we'll shift a little bit and look at what about older kids? This is mortality for children and youth who are ages 5 through 24, so school age up and through young adulthood. And an additional 2.1 million people in this age group died in 2022. So that's in addition to the 5 million we already talked about in under 5. That's 16 deaths per 1,000 people, and I put that into that context just to think about the massive impact that is if you think about 16 deaths for every 1,000 kids and youth 5 to 24. And that disparity by region still exists. So when you look on the right there, you see the mortality rates in different age groups, starting high with 0 to 4, going down in the school age 5 to 9, and then kind of rising up again. And each of those lines is a different region. So the top line is Sub-Saharan Africa, still having the highest mortality and quite a bit higher than the black line in the middle, which is the overall world average. And then again, lowest is Australia and New Zealand at the bottom. Now we'll talk a little bit about causes. What's causing all of these deaths around the world? So this is for under 5 mortality. This is the most recent data that shows the causes of death for kids who die under 5. And that large blue triangle there that says 18% is prematurity. And certainly over time, we've seen a larger proportion of the under 5 deaths is made up by neonatal deaths, by prematurity or asphyxia or neonatal sepsis. But I want to call our attention to the diagnoses here, which I think we would all agree are treatable diagnoses. And so these are still really high and represent a large proportion of child mortality, under 5 mortality around the world. That's pneumonia, malaria, diarrhea, injuries, sepsis, tuberculosis, measles, meningitis, and encephalitis. So these are all diseases where children left untreated would become quite sick, would have life-threatening illness, but with proper emergency stabilization, with recognition of illness, with life-saving early interventions and supportive care, these are survivable and treatable diseases. These are causes of deaths for adolescents. So now we're looking at the causes of deaths for 10 to 14-year-olds. So you still have these communicable and non-communicable diseases, but now you have injuries and trauma, road traffic accidents, self-harm. And I'm trying to make the case here that these are also diagnoses which are commonly cared for with emergency and critical care. There's several studies from around Sub-Saharan Africa showing that the timing of mortality for kids who show up to the hospital is early in their stay. So depending on which hospital you look at, and there's several countries represented here, of in-hospital mortality, 31 to 66% of that is going to be within the first 24 to 48 hours after arriving to the hospital. And largely this is because kids arrive so late in the course of their illness. They're already quite sick with life-threatening illness when they arrive. And so if they're going to make it, they're going to die, it's going to be within that first day or two after arrival. But there have been studies that have shown implementation of triage and trained emergency specialists right at the door when they entered and recognizing that they're very sick and getting them what they need quickly, as well as some critical care support has been associated with decreased mortality. So it's not something that is something that can be improved. And just a word for those who might not have the context for low and middle income countries and barriers to trying to access care. Kids show up sick for a variety of reasons that really start at the home. They may live in families who experience poverty. There may be low levels of parental education. Many children still live with malnutrition, chronic malnutrition, and that makes them more susceptible to disease and to getting sicker quicker. When they realize they do need to seek care, there may be transportation barriers. They may not be able to afford the ride to the hospital. And there also is very limited pre-hospital EMS throughout Sub-Saharan Africa. It's real limitation in getting to the hospital. Once they get to a primary care center, they may find that there's lack of supplies, there's lack of staff, it's underfunded. And if someone there recognizes they need to get to a referral center to get advanced care, there's weak referral systems, there may be lack of staffing also there, lack of trained subspecialists, lack of supplies. So it's really across this continuum that we see kids showing up quite sick and needing quite advanced care. There's a shortage of doctors around the world, another problem. This map shows us the density, the proportion of doctors per capita by region. So now the darker countries have higher numbers of doctors, and the numbers of doctors are in those lighter regions. So again, we see Sub-Saharan Africa having the lowest proportion of doctors per capita for their population. And if we pull out Kenya and the US, since that's what we're talking about today, we have one doctor per 10,000 people in Kenya, and 36 in the US, so a 36-fold difference in doctors per population. And this pattern really holds for nurses. So this same map now with the density of nurses per population, and the darker colors have higher amounts of nurses, the lighter colors have lower amounts of nurses. And here we see in Kenya, it's about 6 nurses per 10,000 people. And in the US, it's 118. And you might notice when you look at the legend there, 118 is actually higher than the high income average of nurses per 10,000 people. And yet, I think we maybe have all experienced in the US, many hospitals hiring nurses from lower income countries who have finished their training there and then come to the US, and they're leaving a place that has really a much greater shortage in nursing. Emergency and critical care are really emerging specialties in Sub-Saharan Africa. So most countries, if they have a subspecialist, like Dr. Kailimia, there are 0 to 5 of them that they have as colleagues. It's a brand new specialty. And emergency medicine itself is also newer. There's many countries across Sub-Saharan Africa that have emergency medicine training programs and residencies and specialties, but there are many that still do not. And the combination of emergency medicine and ICU is really novel in the region. It's novel for Kenya, but it's also novel in the region. There was recently a working group of almost 300 global healthcare workers who came up with sort of essential emergency and critical care elements. And they worked together to identify what are the things, what are the equipment, what are the care procedures, what needs to be in place to really save lives around the area, around the region, that's both emergency and critical care. So it was a merging of the two. And then at the WHO level, there's also been movement and more emphasis in that as well. So previously, kind of an older, we have the ETAT guideline, the Emergency Triage and Treatment Guidelines, which show there's training for healthcare workers who might be of any background to care for sick kids with common conditions, so sepsis, respiratory distress, seizures, altered mental status. And more recently, there's a basic emergency care course, so that cares for all types of emergencies from adults and kids. That's a WHO course. And then there's been even more of an emphasis with this new portion of the WHO website dedicated to emergency and critical care, and a recognition that whereas WHO, sort of historically has disease-specific vertical programs, emergency and critical care is this cross-cutting set of specialties which cares for the end stage of all of those diseases before there is mortality and potentially preventing deaths. A couple of recent publications from that website that you can read more if you're interested. A global mandate to strengthen emergency critical and operative care and emergency health care in crises. This one was just from earlier this year. And that comes, after COVID, disaster preparedness. We think about pandemics and the connectivity of our world, and also humanitarian crises and climate change. And all of those things sort of call for an emphasis on emergency systems. So now we'll shift a little bit to talking about Kenya, and then I will stop talking and hand over to my colleagues. But the UW and Kenya have a really long history of partnership, and I hope we have many online today. We're in an evening time in Kenya, and here who are parts of these institutions. But there's the Kenya Medical Research Institute, which does an enormous amount of impressive research, some of it with the University of Washington. University of Nairobi has a huge amount of training programs. Kenyatta National Hospital, which Kenya will tell us more about. Here we have the Department of Global Health. Within the Department of Global Health, we have WATCH, which is Women, Adolescents, and Children, and the Kenya Research Training Center. Both of those have many ongoing rich collaborations with people in Kenya for 20 or 30 years probably. And then we have the REACH pathway, which I was a resident in, and then now I'm faculty for. It's called CHEP in Kenya, and that's been around for 15 years as well, with residents going back and forth and learning from one another, both in Kenya and in the US. This is from a REACH trip in December 2010. So now I'm dating myself a bit because I was a resident there when Dr. Stapleton came back then to see the program. This is from Kisii, Kenya. And this is earlier this year with many people in this room. In January, we're in front of Dr. Kailimia's unit at Kenyatta National Hospital with Dr. Walker Harding. And just a brief word about global health partnerships before we talk about the partnership which started PEC Kenya. Historically, there have been a lot of problems with global health partnerships between high and low income country universities. With the neocolonialism, a problem with research funding where the money all goes to benefit the priorities of the high-income country partner, power dynamics, and a lack of transparency. And more recently, the field has sort of embraced these guiding principles of mutual benefit, of equity, sustainability, inclusivity, and a real humility when we approach these partners to know, we have so much to learn from one another. And it's a true exchange of education in both directions, and we're both better for it. And so guiding principles and operating principles that are really important to us are joint decision-making, joint processes and governance, and really deciding together what are the outcomes that we think are important, that we want to measure to make this partnership strong and impactful. And the goal is really to decolonize global health. So now we'll turn over to Amelie to talk about the development of the Pet Kenya Fellowship. Thanks.
All right, so let's shift to Kenya. So Kenya is a country in East Africa, as you can see here, with a population of almost 50 million people. It's a very young population with an average age of about 19 years. So 38% of the population is 15 years old or younger. Kenya has made significant strides in their health indicators that have improved over the last 2 decades with an under 5 mortality that declined from 86 to 41 per 1,000 in the last 2 decades. Its healthcare system has both a public and a private arm, with about 60% of healthcare facilities in the public sector. So when I first traveled to Kenya in 2011 as a second-year pediatric critical care fellow with my UW mentor, Judd Walson, I was trying to and looking for a research project in pediatric sepsis within one of Judd's large trials. At that time, I met Rashmi Kumar. She had just finished her pediatric critical care training in India and had just started working at the University of Nairobi and Kenyatta National Hospital. Kenyatta National Hospital, as you will hear from Dr. Kilimia, is the largest referral center in East Africa and in the public system. And so she was their first pediatric intensivist. There was no dedicated pediatric ICU, no dedicated pediatric ICU nurses. And the mortality, as you can see here, when she started in 2010 to 11, was almost 100% for critically ill children at her institution. However, within a few years of her very, very dedicated work and trying to train residents, nurses, developing protocols for pediatric critical care, doing QI interventions, she was able to decrease mortality by almost 50%. So we connected, and it was clear that she needed help in taking care of this ongoing stream of pediatric critically ill patients. And at the time, the only training program in pediatric critical care was in South Africa. And it was an excellent program called the African Pediatric Fellowship Program in Cape Town. But because it was the only one for the continent, it was overrun and not enough for the need. So we developed the vision of creating a collaborative training program in pediatric critical care in Kenya for pediatricians from Sub-Saharan Africa. And given that emergency medicine was still at the time an emerging specialty, as Emily explained, we had the vision of combining pediatric emergency and critical care as a combined training program. This was a very novel idea at the time. Kenya had only had one previous clinical fellowship training program that was in pediatric anesthesia, so the concept of a fellowship training after residency was very new. At the same time, although our institutions had reports and excellent relationships on the research arm, there hadn't been any collaborative clinical training programs between our institutions. So there was no blueprint to go by. But we felt that this approach of training Africans in Africa was really important because bringing them to high resource settings has the impact of potential brain drain, which we wanted to avoid. So these are the steps that we went through for program development. And although they look sort of clean and straightforward, they were everything but that at the time. So they involved recruiting faculty for the fellowship, getting institutional support, and creating a global partnership, eventually developing a curriculum for the needs and resources in East Africa, implementing the program, and then the hardest task, finding funding. So I'll go through some of these points in more detail. So here's our Kenyan team that we gathered. Dr. Kumar, I already told you, and Dr. Reel at the University of Nairobi. Later, after we've started the program, Dr. Kailimia joined us as one of our first graduates, which we're so fortunate about. We then recruited Dr. Marty Steer and Ariana Shirk from Kijabe Hospital, which is a rural missionary hospital. And they were at the time the only pediatric emergency medicine doctors in the country. We had initially a lot of frequent meetings to sort of create our mission and collaborative partnership. This partnership, or the mission statement of our partnership, is to improve management and outcomes of critically ill children in Sub-Saharan Africa through education, research, advocacy, and global partnerships. Creating a global partnership required a fair amount of institutional and leadership support between the existing institutions, and we are so grateful to our division and I see some department leadership to get this done, both in Nairobi and in Seattle. As Emily mentioned, effective partnerships should be collaborative, bidirectional, and sustainable with strong leadership from host partners. I don't know if we always got this right, but we certainly tried. It was clear from the beginning that the University of Nairobi would be the site to own the program, and we would just be there to help make it sustainable. So we went through several steps of developing the curriculum. We used the framework of Kern's 6-step approach in this process. We already talked about steps 1 and 2. The next steps, formulating the goals, developing educational structures, program implementation, we'll talk a little bit more about. I love this picture because this was a very long process. We started the fellowship, the vision, in 2019, and I think all of us in this fellowship faculty group did lose hope that this would ever come to fruition. But I love this picture from the American Academy of Pediatrics meeting in San Francisco in 2016. It gave me hope several times in that process that we could actually do it. And for any people from Sub-Saharan Africa on this call, if you just believe in program development, you can do it. So these were the goals that we initially created, and I would say we're somewhere in the medium-term goal section. The program is not quite self-sustainable yet, but almost, we have decreased child mortality at the PCC training sites, not us, but really our Kenyan collaborators. Dr. Kalimia was just telling me that they are working on more clinical protocols for their unit, but also starting to have discussions about national guidelines for critically ill children. So the curriculum process, development process, was obviously a central part of program development. After some significant prep work, we all met in Nairobi to discuss the content of this. Professor Obimbo here in the center very strategically also invited stakeholders from the Kenya Pediatrics Association and the Ministry of Health to be part of this process. And so their approval was guaranteed because they were part of it. The focus was to develop a curriculum that would be relevant for critically ill children in these resource settings, and with the resources available for the disease processes that are relevant in the Sub-Saharan African context. It was an iterative process with fascinating discussions about what a country like Kenya needed at the time, and also with a vision of what they might need in a few years as the country is rapidly progressing in their healthcare system. So then in late 2018, we were finally able to have the curriculum approved, and in 2019, the fellowship started. So the main two training sites are Kenyatta National Hospital and Kijabe Hospital in rural Kenya. Most rotations are at Kenyatta National Hospital and include rotations through their ICU, the anesthesia department, radiology, cardiology, etc. In addition, we do remote weekly to bi-weekly lectures on pediatric emergency and critical care topics, journal clubs, board review sessions, simulation sessions, and had also early on, as Emily mentioned, planned for bidirectional exchange of fellows, which now we're finally doing with Dr. Kalimia. In addition to the clinical rotations, we also included some basic research skills in order for pediatric emergency and critical care to be successful in these settings. Since it's all new to this region, it's really important to study it. It's important to look at the outcomes and see which interventions are working. And so having some basic research skills is of importance, as well as leadership training and implementation science training. Our fellows are becoming leaders in the field of pediatric emergency and critical care in their hospitals, but also in their regions. So that is something we included in our curriculum. We couldn't do this work without the significant support from volunteers all over the world. So we have a huge team here in Seattle who has helped to facilitate training both in person and remotely. Suzanne Mazer has been to Kenya multiple times and helped in that process. But we also have many volunteers in other institutions globally, more than 100 volunteers from 40 institutions and 11 countries. So here are just some pictures from some of our educational sessions. Really, most of the training is done on a day-to-day basis by our Kenyan faculty. Here, Dr. Kalimia is placing a line with Dr. Rio, and over there with Dr. Kumar. And we have here we have Dr. Monique Radman from our CSCU visiting and teaching in pediatric cardiac critical care. We do a lot of simulation, both in person, and Emily runs virtual simulation sessions monthly, which are really fun. And so we do a lot of remote sessions, as you can see here, and the COVID pandemic has forced us to do more of those, but that has actually helped us getting the program more sustainable over time. So here's a quick timeline from sort of the initial vision in 2012 to where we are today. It took 7 years to plan the program, develop partnerships, curriculum, get the curriculum approved, and fundraise. And in 2019, our first fellows started, and now we have 11 graduates and 3 current fellows. We as doctors are useless without nurses and mid-level providers. So Kenya was really a front runner in training not only doctors in pediatric emergency and critical care, but also nurses at Gertrude's Children's Hospital and clinical officers, which are equivalent to our APPs or nurse practitioners. So since 2013, there has been a program in critical care nursing at Gertrude's Children's that now has graduated over 274 nurses, and the pediatric critical care clinical officer program at Kijabe Hospital has had an immense impact on management of critically ill patients there, and they have graduated 26 folks so far. So where are our fellows from, and where are our graduates now? So our 11 graduates are mostly from Kenya, 7 of them, but also from Rwanda, Tanzania, Nigeria, and Ghana. We have 2 further fellows currently from Kenya and 1 from Sierra Leone over here. Our graduates, 80% of them work in the public sector, the majority in tertiary care centers, and the majority of them practices solo, so they do not have colleagues to help them in pediatric emergency or critical care at their hospital. We do biannual evaluations of our fellows and, program evaluations that our fellows do, and overall the rating and program organization and clinical exposure and sort of their learning and health systems improvement has been very high. So funding has been very challenging from the beginning. We have been basically operating on a shoestring budget, mostly to provide stipends to our fellows. Capacity building is just not very well funded globally. So we were mostly dependent on grassroots support, and very quickly had to learn that the usual academic route was not going to be successful. So thanks to our amazing community members, one of them is here, Danielle Clark, we were able to fundraise, and both Danielle Clark and Caroline Egan actually created a Seattle Children's Global Health Guild to raise startup funds for us and get the program off the ground. Since then, our Kenyan colleagues, especially Professor Wamalba over here, has been able to get support from the Elma Foundation that has largely been supporting our Kenyan fellows with sort of living and tuition stipends. We are so thankful to our Department of Pediatrics here at the University of Washington and our divisions of Pediatric Emergency and Critical Care as the main other sources of our funding. We're very excited about our Leslie Walker Harding Scholarship that we were able to give to one of our fellows this year for the first time. So now I'm going to hand over to Dr. Kalimia talking about Kenyatta National.
Good morning, everyone. Again, thank you for this opportunity to present in your ground rounds. So in the next few slides, I will go through an overview of Kenyatta National Hospital and the pediatric critical care experience at KNH. So Kenyatta National Hospital is a level 6 national teaching and referral public hospital located in Nairobi, Kenya. It is currently the largest referral hospital in East and Central Africa. It has a total bed capacity of 1,800 beds, 50 wards, 22 outpatient clinics, 24 theaters, a pediatric emergency unit, and an accident and emergency department. The pediatric bed capacity is approximately 400 beds. This is spread across the 4 general pediatric wards with a bed occupancy rate of greater than 100%. The hospital receives patients from all over the country, with the main catchment area being Nairobi County, where it is located. The hospital has a standalone pediatric ICU, which has a 5-bed capacity and an average admission of 20 patients per month. That translates to 240 patients per year. This represents less than 30% of the hospital needs. The general pediatric wards has an average admission of 600 children per month, and therefore the pediatric ICU offers very limited bed space for the huge hospital needs. Apart from the pediatric ICU, the pediatric critical care team reviews critically ill pediatric patients admitted in the adult ICU, in the pediatric surgical ICU, and the cardiac critical care unit. We also do reviews of critically ill patients in the acute rooms in the general pediatric wards. These acute rooms serve as HDUs, and most of the patients in these units require ICU care, but are not able to receive this care due to the limited bed space. The team also covers emergencies in the pediatric emergency unit and reviews pediatric trauma cases that are received in the A&E department. So most of the patients that we admit and we see in our unit have a diagnosis of septic shock. This is at 32%, followed by pneumonia at 28% and acute kidney injury at 18%. From this graph, we can see that there has been a steady decline in the under 5 mortality in the PICU at KNH from 60% in 2018 to a current 36% in 2024. This I would attribute to the increase in the number of specialized staff, both doctors and nurses working in the PICU. In regards to mortality by age, 56% of our mortalities occur in children less than 1 year of age, followed by 27% in children 1 to 5 years of age. The rest of the mortalities you can see are spread between the age groups of 5 to 9 and 10 to 12. Our pediatric ICU is run by one Kenyatta National Hospital pediatric intensivist, one University of Nairobi pediatric intensivist, with support from the Pediatric Emergency and Critical Care Fellows and the pediatric registrars. We have our day and night coverage done by medical officers. These are medical student graduates who have completed 1 year internship post-undergraduate training. We also have other subspecialties who are available on consultation. From the nursing team, we have 3 nurses working per shift and 1 team leader nurse who works as a runner nurse, assisting nurses on the ground, ordering medications and ensuring smooth running of their unit. The nurse to patient ratio is usually 1 to 2 and on some occasions 1 to 3 in the PICU and 1 to 12 patients in the acute rooms and the wards, which serve as the HDUs. We also have auxiliary staff such as occupational therapist, physiotherapist, a social worker, nutritionist, a records person, and cleaner. All of these staff are shared with the pediatric department except the nutritionist and the cleaner. Currently, we have no pharm tech or clinical pharmacologist as part of our team. Our nurses work in 3 shifts. They have a morning shift, an afternoon shift, and a night shift. For our equipment and consumables, we have limited cardiopulmonary monitoring accessories. We have monitors which are only partially functional. We currently have 5 ventilators, 3 high-flow nasal cannula machines that are currently not operational. We have 1 point-of-care ultrasound machine, and we struggle with frequent stock-out of our central venous catheters. So what are some of the challenges that we face in our PICU at KNH? One is space. We have very limited bed space to cater for the huge demands that we receive from all over the country. 2 is lack of essential medical equipment and supplies, and this has inhibited our ability to give the best possible care. 3 is staffing constraints. We have a lot of staffing issues, as you can see, both in number and deficiencies in trained personnel. That's for both doctors and nurses and also auxiliary staff. We have also not yet put in place proper systems in our unit, but we are currently working on it through development of nationwide pediatric critical care standards. Now, despite these challenges, we have definitely seen a big change in our outcomes of critically ill children, but I believe that there is still room for more improvement. And for this to happen, there needs to be an increased focus and advocacy, especially in the low middle income countries, in pediatric emergency and critical care.
Great. Thank you, Dr. Kailimia. Where are we now in Sub-Saharan Africa in terms of pediatric emergency and critical care? So it's so exciting, really, to see how new leaders build pediatric emergency and critical care infrastructure and are training in various parts of Sub-Saharan Africa. We all really together need to address this overwhelming global healthcare work crisis and need really accessible, high quality, and reliable training capacity for that in low resource settings. So here are some examples of emerging pediatric emergency and critical care infrastructure and training programs. So I'm very excited that Dr. Tigis Bacha in Addis Ababa at St. Paul's Millennium Hospital earlier this year started her own pediatric emergency and critical care fellowship. We have in Ghana Dr. John Apia, who is starting a fellowship in pediatric emergency and critical care next month in Kumasi, Ghana, with one of our graduates helping him in that process. There are plans of pediatric emergency and critical fellowships both in Kigali in Rwanda with one of our graduates, as well as in Dar es Salaam in Tanzania with one of our graduates. In Kenya itself, the pediatric emergency and critical care infrastructure has greatly progressed. So we have ICUs that are expanding in Kisumu, in Mombasa. There's a group working on another fellowship program in Eldoret in Western Kenya. And Kenyatta National Hospital is working on constructing a 22-bed new pediatric ICU, which is very exciting. In January of this year, we visited Kenya with our department chair, Dr. Walker Harding, and we visited Mbagathi Hospital, which is sort of a district hospital right across the street, actually, from Kenyatta National Hospital. It's a small hospital, and one of our graduates, Dr. Rukia Aden, is working there as the only pediatric emergency and critical care doctor. And it was lovely to see how, when we visited, she showed us the pediatric ICU that was under construction right behind us. And while we were there, her boss showed up and she started advocating for more pediatric ICU beds. It was a lovely process. And Rukia, if you're on here, on this call, good job advocating. So what is in the future for pediatric emergency and critical care in Sub-Saharan Africa? So capacity building really is only one piece of the puzzle. Emergency and critical care is such a vital and neglected part of this healthcare system. And we know now that essential emergency and critical care systems are actually feasible to implement and are cost effective. So for pediatric emergency and critical care capacity building, we need to think not only of doctors, but also nurses and other healthcare providers. And we all have to work together to get there. Ideally, with shared pediatric emergency and critical care educational networks. We are starting to share some of our remote training resources with the program in Ethiopia and hope to do so with other programs that are evolving. We don't only need education, we really need a research network in Africa run by Africans to investigate pediatric emergency and critical care outcomes, think about best practices, guidelines, and also resource allocation. Resource allocation we haven't touched on, but it's a very challenging part. Who should get the limited resources? Which patients should get resuscitated? And when we take away resources to a critically ill patient, we're taking them away from other parts of the hospital. So this is a very complex process that we need to investigate in detail. So we also need to advocate, just like our graduate, Rukia Aden, for pediatric emergency and critical care infrastructure and obtain more funding to improve all that infrastructure. We couldn't have done this work without significant support of all these leaders. Professor Abimbo, Wamawa, and Irimu are the past and current chairs of the Department of Pediatrics and Child Health at the University of Nairobi, and Dr. Bruder Stapleton and Leslie Walker Harding. They all have been essential parts of getting this program off the ground. Thank you very much. Thank you to our UW and Seattle Children's colleagues, mentors, and friends. It's a huge group. I hope we captured everybody. We couldn't have done this without you. Thank you all. Can we have a round of applause for everybody? We're not done yet. Thank you to all our colleagues globally, our mentors, friends who are volunteering on a regular basis, either virtually or in person, to teach our fellows. Thank you, all of you online, for being there and helping us. If you want to know, however, who is really running the program, it actually is Trish Firth. Oh, yeah. She runs us. Please applaud for her. Trish, we couldn't do this work without you. Trish coordinates everything, reminds us of everything, and both here and in Nairobi, so thank you very much. if you want to get involved or support our program, here's our email, and there's a QR code to our website if you want to know more. Thank you so much.
Thank you so much. That was wonderful. We really appreciate all the work that you're continuing to do, all of you. For those of you in the room, if you have a question, if you could raise your hand, I will bring you this microphone so that the people online can hear you. And if you're online, type away and I will read out your question.
Thank you. That was an amazing presentation, and your work is so inspiring, and I just feel like everything that you presented doesn't reflect the hard work and sweat that you've put into this and many people have put into it. It is truly, truly amazing, and thank you so much for this presentation and your work. I do have a question. I'll preface it with, we're learning more now that post-discharge mortality in low and middle income countries, that the post-discharge mortality rate is as high as it is in the inpatient setting. And so I'm just wondering if there's an opportunity to follow the kids that are discharged from the PICU or the PICUs, from the, with your graduates, to better understand if the care that they're receiving in the PICU is also reducing the post-discharge mortality.
Okay, thank you for your question.
Okay.
Sorry. Is it on?
You can use this one. There you go.
Thank you for your question. I think that's a great idea because we currently don't have any data, and I mean because of our issues of access and also getting to see, we don't have social workers going to see the patients post-discharge, so we actually have no idea what happens to them post-discharge, and I think it's an excellent idea and something that we can do because I think currently everyone has a mobile phone. And I mean, to start with, we can start with, interviews because we generally get their data in terms of their phone numbers, their names, and I guess we can interview them and get a bit of information regarding their clinical outcomes post-discharge. So I think it would be an excellent idea.
I think just to add, I think one of the things that you do in your unit is you really keep the patients in the ICU until they're almost ready for discharge, which is probably not the right resource allocation, but I think you work so hard on getting them from almost dying to, much better that that is one of the ways to, I think, decrease post-discharge mortality is just to make sure that they really look well at the time they leave the ICU.
This is amazing to hear the story of how this all started, having only seen it in the last couple of years. One stakeholder I didn't hear you mention was the Ministry of Health. How tough was it, or did you not even involve them, go around them? That's always a good solution too. When they have so many competing priorities in their budget and in their mind of how healthcare resources should be allocated, did you get pushback? How do you justify this when they have 2 malaria vaccines and now they got to get out to the countryside and the WHO is saying you need to prevent malnutrition with these small quality supplements, and primary health care is still lacking in many places? Did they say, well, this is too much money for a small number of kids? How did that work? Or you went around them?
Yeah, I think we need a tiered approach to pediatric emergency and critical care. So this is why Emily was talking about essential emergency and critical care, which really is not very resource intensive. It's IV fluids, it's oxygen, it's giving timely antibiotics, which can be done at every level of, in the hospital, in the healthcare system. So, but at the same time, I think having some referral hospitals that are able to provide further level of care is very important. And I do agree that I think it's really important to study the outcomes and cost effectiveness of a lot of those interventions that are being done. And I think we need a lot more funding and especially data to do that and understand what works, what should be invested in. But I think overall, we should strive to a healthcare system where pediatric emergency and critical care is part of. and training leaders in those skills who can then train residents and other parts of the healthcare team who then bring that training to other levels in the healthcare system is very important.
I was just going to add, I don't know specifically about the Kenyan Ministry of Health to answer that question, but certainly the University of Nairobi, the head of department of University of Nairobi has a lot of jurisdiction over priorities, especially when it comes to training. And I think that they would be like very high up in the ministry in terms of decision making and resource allocation. And when we were there in January, we met with the department, and they were very much pushing forward on this idea of fellowship, so that they have their local subspecialists who can train their local pediatricians. That's the place that they were at, ready to push the envelope of increasing the access to subspecialty care. And then just as a country, I was in Malawi recently, and they released an emergency care plan for the country. I feel like with this WHO emphasis, like it's becoming something that countries are realizing. You can do a lot of malaria vaccines, which are very expensive. When kids still get malaria, they shouldn't die of it in the hospital. Having access to emergency triage, to IV treatments, to oxygen, to high flow nasal cannula, intubation, even if they need it, it's crucial life-saving care. And I feel like it comes up more and more in the priorities across different countries. Do you have anything else?
Thank you. I think we got Dr. Walker Harding unmuted, so let's see. Leslie, you are on next.
It's great to see you all, and thank you so much for all that you have done. I think it's been such a wonderful, skillful shepherding of this program and the collaboration, and really, to such great success. It's really phenomenal to see some of the results that you're talking about. What I'm interested in is what lessons learned have you had that you've been able to bring back to Seattle? Having been there and seen, there's different ways of process to get things done that I thought were really very different than what we do sometimes, and we take a very long time sometimes to make decisions, and and in training or just in care, like what lessons have you learned that you kind of brought back with you to help us here, and what's your next steps?
Thank you. That's a great question. So I think lessons learned are we are all in this together. We all need to work together to increase capacity. In terms of what personally, I think this program and experience going and training in Kenya and doing clinical work there, I think is echoed by many of our volunteers. Is that we really here have nothing to complain about. We do not really have a lack of staffing, although we complain about it all the time. It is lovely to teach our fellows over there who are really hungry for knowledge, and sometimes I wish it would be like that here. The other thing is that I think next steps are really to create a network of pediatric emergency and critical care training institutions. We're all trying to do the same thing. There's not a whole great number of us, but I think we can all do it together and share resources, and I think that would be the next step.
I was just going to add, I think this sense of this very inspirational sense of being able to do sort of whatever needs to get done. I think about Rukia, who we met at her county hospital with no critical care and no, barely any oxygen concentrators. She's got kids on high flow. There's a unit being built for her. You see things it's just very inspiring to come back over the years and see how much people like Dr. Kailimia and Dr. Aiden are changing the face of outcomes there. And I think it's kind of that inspiration, and also just that reminder that, things might seem impossible, but, if you really care and you really work hard at it, kind of sounds cheesy, but you can get amazing things done. I think that's sort of the inspiration that I bring back. I don't know if you have any comparisons between the worlds. Kenya was at Harborview all day yesterday, so I don't know if she has any you said this, Kenya. You're lucky to be able to see these two worlds. It's a huge privilege to be able to go back and forth and connect our worlds, because we all have so much to learn from each other.
Thank you so much. I think there's just a few more comments in the chat, so I'll use them to wrap up our hour. And again, we really appreciate all the hard work that you and all of your teams have done, and especially Kenya for coming all the way here to spend 2 weeks with us. Just a few comments, which I think everyone here echoes. Thank you so much for a wonderful presentation, all the hard work, deeply impressive and inspiring. So thank you so much. Thanks everyone for being here, and we'll see you all next week. Thanks, you guys.